please just let me know if you can hear me. All I need is a couple bubbles, and then I know that the sound quality is good to go, and we can continue. All right. Okay, cool. Okay, so I wanted to start this week off with addressing a couple questions. I'm really proud of you guys. You guys were coming through with the material and you checked out the reading, and you feel like you found a couple discrepancies. So let's talk about it. This is slide 21 in the Intro to Geriatrics slide or PowerPoint presentation from last week. And one of the questions that asked was, and I think I addressed this briefly, but last week we talked about the most common conditions, chronic conditions in the elderly. Um, but this reference actually in chapter 54, page 1126 in your Sousa text, it's a little bit different. It's a little bit out of order compared to what's in the Sousa text. So we'll go with the Sousa text will override the PowerPoint, even though the Sousa text is a little bit older. The references are a little bit older because it's a textbook. This is more up to date. Let me see if I can get my thing. This PowerPoint is actually more up to date. However, you won't be asked like what is the number one most common condition. You will be asked to select from a list of most common conditions. So you need to know, for example, here we have high blood pressure being number one, but in the Sousa text is number two. Okay, and in the Sousa text, osteoarthritis is number one. So we'll go with osteoarthritis being the most common, and two, hypertension or high blood pressure being number two. But you still need to know that high blood pressure is in there. High cholesterol and heart disease are going to be in there. In your Sousa text, so go with the Sousa text, okay? The top 10 in the Sousa text. It's older. This PowerPoint is more up to date. So for testing purposes, if you wanted to memorize them in order, really, I just want you to know 1 through 5. You need to know, just be aware of the whole list. But if you look, a lot of the conditions are on here. So I'm going to read in the Sousa text. Number 1 is osteoarthritis. Number 2 is hypertension. Number 3 is hearing impairment. Number 4 is heart disease. And number 5 is some type of orthopedic deformity or impairment. So something with their walking or anything like that. Then 6 is chronic sinusitis. 7 is visual impairment. 8 is diabetes. 9 is varicose veins. And 10 is an abdominal hernia. Okay. A lot of these conditions will get talked about in class. Specifically, we'll talk a little bit about hypertension and cholesterol levels. Not too deep into heart disease, more like blood vessel disorders. We definitely will be talking about arthritis. We won't hit big on diabetes. Diabetes will be mentioned, but it's not going to be a high focus. And we won't really talk about kidney disease. Depression is part of the intro material, so that is in the reading. So prepare to see some questions on depression. Even though we didn't talk about it much in the PowerPoint, our geriatric age population does go through depression quite frequently, just because there's change of life transitionings that's happening with them. COPD and Alzheimer's will definitely be discussed. I'm going to pause for a second to see, are there any questions? So that was one of the first questions. So this is more up to date. However, the Sousa text will override because there are some discrepancies and there are some differences with the conditions. And if you look at the Sousa text, some of these questions were pre-test questions and things like that. So you really, top 5, you really just want to pay attention to those, okay? Because a lot of people think diabetes is one of the tops, and high blood pressure just tops the list almost in majority of the populations as we get older. High cholesterol is going to run up there with that, and anything with the heart. One thing that I do want you to be familiar with, and this is on the same page as in the Sousa text, is that the doctor, when you deal with a senior patient, and this is where senior evaluation comes in going into week 2, the geriatric age population does not always follow the rules, okay? Meaning, like, for example, we're going to talk about flu. Most people in a general age population under 65, when they get the flu, they get a fever. The geriatrics may not, because you can see this directly in our Sousa text. Their symptoms can be atypical to whatever is normal. Because with the geriatric age population, the weakest link, the most vulnerable organs to them are the brain and the cardiovascular system. And we know those are very big deals. So a geriatric age population, they're going to have atypical and sometimes vague symptoms. So you want to keep that in your forefront. And one of the goals you want to always remember with our geriatric age patients is that seniors who are successful at aging are more active physically and socially and can adapt to any changes that are happening. So with our case study, you want to keep that in mind, okay? So the last question was about age-related changes to the spine in one of the questions. So it looks like there was a typo in one of the questions, so I'll go back and correct that. But you do want to know that our age-related changes, our elders are more prone to stretch injuries compared to their younger predecessors or their younger versions of themselves. So as we get older, you really, really want to know that. As a reminder, with your case study, you do get multiple attempts at that. It's not an unlimited attempts. Now, with your case studies and things like that, you will not get the right answers. Like the answers won't be revealed to you after you take it. So next week, because case study 1 isn't due till midnight, we're not going to go over the answers. We can talk about any questions you have and go through any reasoning that you may have. However, the answers will be revealed next week. And also after the due date, then you can go on and look at the answers, and the answers should be available to you. Are there any questions thus far dealing with last week's material? Okay.
Dr. McLean, I have a question.
Yeah.
Okay, so if I need to know why this answer was correct for the case study, I need to wait until next week, right?
Yeah, or what you can do is, because one of the students took it, you can take advantage of, you can come to office hours. You could just set up an office hours appointment with me before class. My office hours are from 9 to 12. So you're more than able to come in and set up an office hour appointment, and I can tell you exactly what you missed if you really want to know. And we can go through some reasoning with that. Does that
Okay.
make sense?
Yes.
So
Thank
some of you feel comfortable having private conversations, you're more than able, or you can bring it to class. I'm sure other students have it as well.
you. Okay, thank you.
Okay, so let's move on. Week 2 gets into geriatric examination, and you also have your first case study. I'm going to open the floor up to see if there are any questions with the first case study. The first case study really correlates with this week 1 material, and you really want to make sure that you're paying attention to the slide that talks about what ADLs are. Okay, you need to know what is a basic ADL, what's an intermediate ADL, and what's an advanced ADL. So let's see if we can find it. Okay. Okay. Examples of regular ADLs. Any regular ADLs are something that if you think about like with your kids or with yourself, stuff that you want to be able to take care of on your own just to maintain your person. Okay, so feeding, bathing, toileting, dressing, moving around, getting out of the bed, getting on the toilet off and on, maintaining continence, and grooming yourself are considered basic ADLs for every person. So think about like if you had your kids or anybody, what you would be teaching them how to take care of themselves. Basically, it's how to take care of yourself in the most basic form, okay? Now, an intermediate ADL would be like preparing meals for yourself, right? Versus a basic ADL would be able to just like lift the spoon and actually feed yourself, right? Intermediate would be the next step after that would be actually cooking the meals and preparing it, okay? Bathing is a basic ADL, but cleaning your own home and all those things, make sure you have hygiene of your environment. Those are intermediate. Using the telephone, writing, reading, shopping, managing your medications. So a lot of these things can be done for you. The only difference is like walking outdoors. So some people can like walk around their homes, but they may not be able to get around very much outside. Managing money is another intermediate, right? When we get into advanced ADLs, those are being able to perform like rigorous activities and all of those things like that. So you want to pay attention to those. And there's no typical age for an elder. Like there's no rule, even though we have those different categories, 3 to 4 different categories on the aging, like young, old, middle, old, and old, old. Age doesn't directly correlate with that, right? Because there are some 85-year-olds who are out here kicking butt out here with their physical activity, and they're in their gyms and they're on TikTok and they're on Snapchat and they're making videos and they're showing everybody what the fitness world looks like for people in their age group. So with elders, we judge them, we base them off their functional activity. What can they do for themselves? That will classify which category they go through. Now, sometimes they give you age ranges in the book, but you just have to remember there's no typical elder person. Look at your own grandparents and elders in your family. Some are more active than others. Okay. So you really want to know the difference between it. The case study calls for you to be able to go through the degrees of severity for disability. So there's no disability and at least one ADL. So if we were to look at the prompt for this week, I'm just going to read it to you guys. So usually you'll be able to see the prompt before the case study is released. So for the case study for next week, you could start to look at the prompt to see where we're going. So this week says a 67-year-old male patient presents to the office after tripping over his water hose. So he tripped. The patient reports mild low back pain. When he's asked over how he tripped over the hose, he says he was gardening in his backyard and just didn't see it. Okay, he just didn't stumble out of anywhere. When asked about his activity level, because with elders we're looking at their function, he says that he walks and swims daily. So he's able to exercise and stuff like that. He also says he gardens. That's not a basic ADL. That's more intermediate and advanced once we're getting into it. But he does admit that he does need help lifting heavy items such as bags or mulch or a can opener. So there are some deficits that we need to look at with those things like that to help you be able to describe this. So you need to be able, looking at that, you should be able to look at the material and determine how he's doing. So for an example, he didn't say anything about feeding or using the bathroom or anything like that. So he may or may not have any basic ADLs. It sounds like he may be having some deficits in intermediate or advanced. So please review these if you feel like you're having some confusion with the ADLs and the case studies. Do we have any question over the case study? Anything? You can go back and open up your case study, even though it won't tell you the answer. It'll tell you each question is like out of 10 points or 5. If you have a 0, that means you didn't answer correctly on those particular questions. So that's how you go back and go through the material and review it to be successful. So looking at that, are there any questions over the case study before we move on into week 2 material? Because as we continue to move on, we're going to cover a lot of material pretty fast. All set. All right. Thank you for communicating, Shane. It's really cool. All right. So geriatric examination part 1. There is an overview video. It's 5 minutes. Please watch that one. Okay. It gives you a good gist to go through the videos. Okay. So part 1 deals with the examination. Part 2 shows you some common conditions that you may see when you go into clinical practice. It may not always correlate with this list, but there's things that you want to be aware of. So getting into the geriatric examination, like I said, I'm not going to fully lecture. I'm just going to go through the highlights. Remember what you're supposed to get out of the PowerPoint. You want to make sure that you can answer these questions. Okay. One key thing that I want you to understand, there is a comprehensive geriatric examination, which what this talks about, and it talks about our roles, and it talks about the functions and things like that. And the comprehensive geriatric examination goes through, and it basically, once a person hits 65 or at a certain age, all these things you just want to be evaluated as a baseline for them, just to make sure that they're tracking right and seeing where they are. So therefore, if there's ever any decline in their functional status or their ADLs, we can kind of pick up where they are. Okay. And this is important because typically some people may not go to the doctor for years and they may not show up until something's going wrong. So sometimes you want to do the geriatric examination to really evaluate that. So I can give you an example. My grandmother went to the doctor. She had the same doctor for like 15 years. Then he retired. So he's basically, when she would go in 3 months. He would renew her scripts, check her blood pressure. That's it. Her new doctor triggered a comprehensive geriatric examination for her because he couldn't find any records for it. And sometimes new doctors will just do that. So what they do is they're going to go through all of these systems and assess them: cardiovascular, vision, hearing, balance, gait. All of these things are going to evaluate all of these things. Sometimes it'll be a questionnaire. Sometimes they'll actually go and do an exam. A lot of times they're the primary care physician. So listen to this. If you're going to a state where a chiropractor is a primary care physician, like in Illinois or something like that, where you have more privileges, There's a difference between being portal of entry and primary care, okay? Because primary care, you might be ordering more labs and all of these different in heavy imaging and all different types of things. You might be literally maintaining these things and monitoring things. So this comprehensive geriatric evaluation or examination is going to be broken up into pieces, right? So he might do a general, or he or she might do a general physical, right? And they may check into your eyes and all of these things, and then they may send you to an eye specialist. So for my grandmother, I think her hearing and her blood work got checked first, then her vision. So over the course of 6 to 7, 6 months, I would say, she went, all of a sudden she was getting referred out to see all these different practitioners. So her general practitioner checked her eyes. He determined that her lens was a little cloudy, so he sent her to an eye specialist who was able to determine that she had cataracts. But they were also able to determine that her vision had changed. So she went to the optometrist too. Now she wears glasses. She hasn't worn glasses all of her life. My grandmother is in her like 75. Now she wears glasses to read and things like that. Um, and there's a bunch of other things. Her blood pressure medication was changed. So all of these things are just a good check for our geriatric age population. That's a comprehensive evaluation, and that's what this PowerPoint talks a lot about. Now there is something called a rapid geriatric evaluation. That is when you do it right away and you cover as much ground as you can really fast. Okay, so while the comprehensive can be broken up over time, okay, the rapid, you're going to do a lot of things up front, because you do that if you suspect that your geriatric age patient is dealing with frailty. So make sure you know the definition of frailty and disuse and all of those things like that, because frailty, they're functional, they can decline fast. So we're going to check all of these things and try to get the intervention to them as fast as possible. Hopefully that makes sense for you guys. So this slide goes over what a comprehensive geriatric examination is. It's multiple, it's interdisciplinary, so it's going to involve multiple healthcare professionals. So this may be the time where you're sending out referrals, or you're going to send them in. Like for an example, we had somebody and we realized like, wow, I don't think they can see very well anytime. We might need to get you back to your primary care physician so they can evaluate your hearing, or we're going to send you to an optometrist. All right. And it's going to look at functional impairments along with environmental and social issues. So are they safe at home? Are they able to, is their home set up for them? Is it successful? Is their home set up for them to be successful? For an example, my grandmother lives in a 3-story house. She can go up and down stairs really, really well, but most of the things are on the main floor where it's accessible to her. She has a bathroom on the main floor, so she doesn't have to go upstairs or downstairs to go to the bathroom. That's not the best for her at that time. This may mean adding rails to their toilet or changing their tub so they can get in and out, all different types of things. And because elders can be neglected, elders can be abused, it's going to evaluate a bunch of different types of things. And it's for the benefit of our elder patients, okay? And it allows for early recognition of problems and impairment, and we can focus on them and we can get them the care that we need, so that they can continue to be successful and have a great physical and social life, because that's a big deal with why some elders go through depression and they go through isolation and things like that. Okay, so we're going to slip through. What are some things that can trigger? So say if they're not 65, or they're a little bit older or under, all of these things can trigger the cause for a comprehensive geriatric examination. They have unexplained weight loss, if you think they're frail, if you think they're going to have a risk of falling, if all of a sudden functionally they just can't do things anymore. Give you a perfect example. We had a patient come to our office. He was an elder man, drove and did everything himself. We've seen this, actually I've seen this several times, right? Where they get to a certain age where they shouldn't drive anymore and their license gets taken at a certain point, and that can be frustrating. Or we had a geriatric age patient been coming to the same office for 20 years. All of a sudden he started to miss a couple appointments. It just didn't make sense, and he said he started to get lost. So he's been driving here for 20 years, and all of a sudden he's getting lost, where it's taking him long, or he's not able to keep up with those things anymore. That's a functional change. If they transition in care, like from a nursing home to a different facility, if they're on a bunch of medications, they're not abiding by their medications, if they're starting to come up with more multi comorbidities, or cognitively, like the guy with driving and functional, that would be an example. Or if you just are concerned about abuse or neglect, they have bruises, any of those things, or they're mentioning things, or they seem jumpy or afraid, okay? There are different domains. with this. So cognitive function, right? Psychologically, their medications can need to be reviewed sometimes. Like for an example, with my grandmother, after we did a medication review, it turned out she, even though she was going to see the same doctor for 15 years, she hadn't been on a cholesterol medication in like 2 years. So it kind of slipped through the cracks. So when they did her labs, her cholesterol levels were really, really, really high. Her diabetes was maintained really well, but her cholesterol levels were really high because at some point one of her medications just didn't get renewed. So, and she's thinking she's doing everything where she's taking her medication, she's trying to eat healthy and all of those things, as healthy as she can. My grandmother still smokes her cigarettes every day, so within reason. Okay. So you want to look at all these things. Elders also, economic things are a big deal. A lot of them are on fixed incomes. All right. Let's skip through it. This is pretty much the gist of it. You want to know just different aspects of it. You really, really want to know the chiropractor's role in it. So you want to know that functional status, activities of daily living, gait speed, falls and balances, all those things we could play a big role. And if we see changes in those, what can we manage? You're going to give the patient different outcome assessments. So some of these things really will just be outcome assessments. And then if there's no need to investigate, you won't go further. But if they have comorbidities, you really want to ask about their past medical history, and you really want to do a good exam. Tanner, we'll look at it, okay? You said on the week 2 quiz. So one of the things is not all of you get the same question, so we'll have to go back and look at that. You really want to look at the assessments. I'll look at it in a second. Tanner, thank you for bringing it up. So assessment for cognition. Sometimes our elders, their cognition needs to be assessed. Make sure that it's normal for their age. Sometimes there's mild cognitive impairment where they're starting to get frustrated with certain things. And then sometimes there can be early dementia. So you want to pay attention to those. You may not be doing these yourself as a chiropractor, but you do want to be aware of these things. So these are the tools that we use to assess. The healthcare professionals use. They may do a mini cog, MMSE, or the Montreal survey, the MOCA. Okay, and there's sometimes it helps you to determine which ones. These are just questionnaires to show you an example of it. So some of them can be the MMSE is a mini mental exam, and it could be like your name, your date of birth, all of those things that you expect them to know. Where are we? Test their memory, give them questions. Sometimes some of these are questions you get if you get pulled over by a cop and they think you're drinking, they're going to ask you some of these too to have you recall. Sometimes there are little performance activities that you can do for them. Hearing, you guys know some hearing tests, you know some visual acuity tests, you also know some cranial nerve testing and things like that. Pay attention to falls. Falls are a big deal for our geriatric age population because if they certain injuries, they can die from them. So it's not something. It's not as simple as like when your 10-year-old cousin trips. Okay. Sometimes this is a big deal. There are some functional tests. One of the big things you always at least want to ask them at least once a year, sometimes twice, is if you've fallen in the past year, especially if they're a new patient or they haven't been in for a while. If they have, um, if they've fallen a number of times, this triggers part of the evaluation that you need to do or needs to be done on them. You might be working with physical therapists or things like that. Or if they've fallen once, but it was a bad injury. I can give you an example. We had a patient all of a sudden, she's a phenomenal lady. She even had a cane, but she started to fall. She didn't have to use her cane all the time at first, but she started to fall all the time. So it started off where I say, since the last time you've been in, have you had any recent injuries, traumas, or accidents? And she would say, yeah, I fell last week, which is interesting. So I'm like, okay, that's the first time we check and there's no major injuries. Then she starts reporting falling more, or one day she missed her visit and the next day she came in with black eyes because she had fallen. That's a big deal. Okay, timed up and going assessment is a big deal. It's simple. You pretty much just have the patient stand up and walk a line and turn around and come back, and you can assess their gait to see if they have any drop foot, all of those different types of things, or if there are any deficits. Um, When you do that, what are you looking for? Is this because of bad joints or osteoporosis? You know, like if they fail to time up and go, if they take longer than like 12 to 15 seconds, or is it because of neurology or both? There are numerous conditions that can show up in our elder patients that can affect their ability to get up and go. And some of them can just be aging, some of them can be arthritis. Sometimes they can't see where to go, or they're just not hearing you. And sometimes it could be neurology, like Parkinson's or any of those different types of things. So these are balance tests that you want to assess as well. Pay attention. We're almost through with this PowerPoint. This PowerPoint goes extensively in different types of gait patterns. You will be asked about different types of gait patterns. So the difference between antalgic versus cautious or senile, right? Antalgic means they're limping or it's because they're hurt in some type of way, versus a cautious one is like when they think they're going to fall, or so they have a wide, their hands are out wide, they're in front of them, their base, their legs may be far apart, kind of like how you guys, if you've ever slipped on ice and you're trying not to fall on a slippery floor, how you might take it really, really slow. And then there are other ones that are associated with certain conditions, Parkinson's gait, where there's no arm swing. We'll talk a little bit about that, and different types of apraxia. Okay. So that's pretty much what we're going to go into. There's a few PowerPoints with references, but you really want to pay attention to certain areas with our geriatric age population. Do we have any questions over this material? Okay, part 2 is a little bit different, and it deals with just some of the most common conditions that you may see in practice as well. And you want to look at frailty, talks a little bit about frailty. The hallmark is sarcopenia, where it looks like a muscle is wasting away and their muscle mass goes down. Muscle mass goes down, your ability to do things. Think about it. Once you get in the gym, you kind of get jacked up. You feel very strong. You feel like you can conquer things. Think of the opposite. The best place to look for is the temporalis muscle. This is a test question. I expect you to know it. This is like a golden nugget. So please know. We get into different types of things. So you want to make sure you check this out. This is a cool PowerPoint. I'm not going to go deep into it. Rotator cuff, some of these are physical things. It's very common in the elders, not because of a particular injury, just because of degeneration from use, because the rotator cuff, the shoulder moves more than any other joint, especially the supraspinatus tendon. So shoulder issues, you want to be familiar with how to treat shoulder issues. And as we talked about last week, soft tissue is a big deal for our elders. Simple Codman exercises and things like this. This slide goes into a little bit about stenosis and the difference between them, different types of bursitis, if it wants to load, which is common in our female patients and laying on their side, and how it can refer to their back, and also just different things when we have changes with their ligaments that are happening. So that's a quick overview of week 2 material. The other PowerPoint, the other little bit of material has to do more with movement disorders. So before we get into it, the videos are really, really good. So you want to make sure that you watch the videos to know what to do. But let's see if there's anything in movement disorders that we need to review. Thus far, are there any questions? I know, Tanner, you said there was something about a miskey on quiz 2. Do you know which one it is, Tanner?
Yes, ma'am. So, excuse me. So,
Okay, which question was it for you?
it was, which of the following is a trigger for a comprehensive geriatric evaluation? And it was a MAC.
Okay. Okay. So, okay. So frailty, cognitive changes, or multimorbidity. So one of the answers wasn't being over 65. So I think, is that what you're talking about?
Yes, ma'am. So being over 65 is not.
It's not always for the whole thing. So let me clarify, because I did just explain that to you. So if a person's over 65, you can do it. So I'm gonna just change the question. So being over 65 can, but it's not the only thing. So it's not the only trigger for it. How about that? So what I'll do is I'll go ahead and give you credit if you put that question in, just because of how I explained it to you. But if they're over 65 and they haven't been checked for a while, then you want to do it. If they're over 65 and they're reporting deficits and things like that, or you suspect certain things, then you want to do it. And you want to space it out. If you think they're frail, then it's a rapid examination. Does that make sense? Let me know if I'm confusing you guys, because I will explain it in a different way. Okay, so I'll go in and let's see. Give me 1 second, because I'm going to update the answer key right now. And all of you who had that question, you will get credit for that. Okay, so as soon as Blackboard updates, you will get credit. So it looks like a few of you got it. So if you answered that question and you selected that, then you just got the points back for that as well. Okay, let me go see. I see in the chat that we had some bubbles going. Okay, cool. All right, so it looks like we're all good. If any point you have any questions and you feel like I'm not getting to it, jump on the mic. This is your time to pretty much review those different types of things. Okay, so before we get into movement disorders, I do want to share with you guys an opportunity that I want to offer you guys. And being in class, you get to hear about it first, so this is awesome. Let's see. Let's make sure this is the opportunity. All right, disregard the date on here because this is from last trimester, but if I can zoom in, you guys get the opportunity to do an extra credit assignment, but it is due today. So it's due today by midnight. Okay, but it's fairly, if you pay attention, you can get, I think you can get it done. I believe in you guys. You guys are in your final year of school. Pick one of the most common conditions. You can pick one that was talked about in part 2 of geriatric examination, and you want to just basically make a treatment plan for it. Okay, you must give it, you can do it in 1 page or less. Okay, so you guys don't need to write a full paper. You just need to be able to describe the differential diagnosis for these conditions. So what needs to be ruled out? For an example, somebody could have back pain and it really could be osteoarthritis. It could be Facet syndrome, or it could be referred from another area. So just think about what needs to be ruled out, what can present similarly. A person can have a shoulder issue, right? And it could be that they actually did tear their rotator cuff, or it could be that they have some scapular dyskinesia, or they may have some tendinopathy going into it. You want to describe the history. What do you expect to see in the symptomatology with those things? For an example, a lot of times when somebody breaks a bone, they describe their pain different from a tendinopathy, okay? So you want to do a little research. You want to use your SUSA book. If you have any of the spiral evaluations books by Dr. Vassant, Dr. Nikki Vassant, that'll help you as well. And where would they point to, and all of those different types of things like that. Like fat pad syndrome is very common in elders, and they typically just point to the bottom of their foot, right? They point to a specific face, but it could be mixed up with plantar fasciitis. So you want to make sure you rule those in and out. You want to describe what their vitals would be, right? If they would be between, if they would be normal, what would be some palpation findings that you can find? What would be some orthos that you would do to help confirm or rule in or rule out? You also want to describe if it's a medical emergency. That is number one. You're going to see that on a lot of cases. Is this an emergency? If it is, do you send? How do you send them? Can they go to the emergency room themselves, or do you need to call 911? A lot of these aren't, but you can choose to do so. Do you need to give a referral, or could you do a referral? If so, to who? And to treat, what would you do? So this is all about management. Management is just knowing what to do and how to do it and all of those things. So chiropractic, what techniques would you like to do, or what areas would you like to adjust, and all those different types of things. With rotator cuff injury, you may be doing some stuff specifically to the rotator cuff. You might also be working with the thoracic spine too as well. And if you were to give them exercises, which areas would you be focusing on? Let's see, you must cite your SUSA text, okay, and say where you got the information found. And your management plan must be appropriate and up to the standard of practice, okay? So disregard the due date, but it's due today, so I'm going to update it, and you get to use it. It's 5 extra points on any exam that you choose, even the final. Now to utilize this, so this is an example. I would adjust the occiput, upper cervical, SI joint to help with proprioception. I would give them glute bridges to increase muscular activation and core stabilization, lower extremity, blah, blah, blah. Treatment plan 8 times a week, twice a week. And the goal would be for them to be able to do their timed up and go in less than 12 seconds and walk an additional 5 minutes. Compared to what they started as. So basically you want to look at functional improvement. You want to have specific goals. So disregard the date. Like I said, it's due by the end of day today by midnight. What you would do is you're going to email that in to me. Once I approve it, then we'll go ahead and submit it through Blackboard and all of those different types of things like that. But you can do this in a page or less, and you get 5 extra credit points. To get the extra credit points, since you can use it on any exam that you want, and we have exam 1, exam 2, and we have the final, on the day of the exam or the week of the exam, you need to email me and let me know that we want to apply your extra credit points. So you have to ask for the points to be applied before the exam is released. That's just one of the rules, and all of those things. All of you will get a confirmation email from me. So, so you're going to email it to me by 11:59 tonight, okay? And then once we do that, I'll be able to go ahead and open it up for Blackboard for you to submit. So I may not have time to create the Blackboard submission right now, so you're going to email it to me at this time, okay? And then I'll tell you what to do if you can upload it to Blackboard. So basically, type it up, write it up, and make sure it makes sense, and just email it to me. Do we have any questions? So this is something that can be helpful. You guys are going into clinic, so you want to get good at doing your treatment plans and making sure that it matches the standard of care. So when your clinician asks you, why do you want to do certain things, you know why, and you have references that can cite that it's really, really good. And you can use up-to-date research, or you can use your textbooks. Those are really, really good. You want to make sure you have sound treatment plans, okay? If they're having, fat pad syndrome, why would you be adjusting their elbow? You got to make it make sense, okay? So I will be uploading this. You need to email it to me. Any questions? It's up to you. You want to make sure you answer all of these and hit all the goals so you can get the full points. Are there any questions? All right. If you do have questions, you can email me, so to speak. Remember, I don't always. Do we get partial credit? Yeah, if it's not complete, you'll get partial credit as long as you do a good job, okay? You can't just write your name and do a rant on there and expect full credit. So okay, cool. With movement disorders, there's only a few highlights that I really, really want you to know. You want to know about the basal ganglia and the parts in the brain that are affected. And you want to know basically the difference. You want to know any indicating features of any issue. So you want to know about the flapping tremors and how basically anytime with tremors, the liver and the kidney can be a part of it. You want to know the different types of dystonia. You really want to know like the different types of cramps and what they look like. So please watch the video so you can know how to describe it. And you want to know basically the features of tardive dyskinesia. You want to know essential tremors. So all of these conditions, you want to be able to know what makes them different from each other. So if you were given the description, you would be able to pick them apart. That's pretty much the essentials of these, okay? So you want to know the difference between an essential tremor. Do these tremors happen when a person is resting or when they're trying to do something? All of these aspects, these are just movement disorders that may show up when you try to assess the gait or movement of your geriatric age patients. Are there any questions? Okay, so here's a review if you need a touch base of how to do some of the upper motor neuron, the pathology tests, any of those things like that. Being that you're Parker students, I know that you're very confident with your neuro, okay? Are there any questions? If not, we will begin to close out. Your case study number 3 is going to deal with week 2 material, okay? So it's going to be asking you about tremors and things like that. It's going to be about a male patient trying to drink his coffee. Some of these things are going to start off simple and you want to kind of weed through. As you continue to go through the curriculum, your quizzes will become comprehensive. So week 3, you're responsible for week 3, week 2, and week 1 material. Any question can pop up on there, okay? Your case studies a lot of times will deal with the week before, but as we go through the try, they may get more complicated. So make sure you're not just flying through the PowerPoint trying to answer the questions on the quizzes, okay? Make sure you understand them. And if not, set up an office hours appointment with me and we'll go through it together. Alrighty, any questions? If not, I'm going to release you guys. I bid you adieu. You have a very, very great afternoon. My office hours are by appointment from 9 to 12 every Friday. So I hope you guys have a great day. Bye. Also, you can watch these lectures, okay? You can always go into weekly lectures and go into the recordings and collaborate.